in 1921, 1922, Benting, a Canadian surgeon, McLeod, a pharmacist, Best and Collins, they were chemists, and they used the extract of crude insulins in the treatment of diabetes mellitus. How they induced diabetes mellitus? They took dog, extract what they pancreatize, when the pancreas was removed, and then the condition of the dog was worsened. And once the condition of the dog was worsened, then they give the extract of the pancreas, and the condition was relieved. So they came to know that there is something that is going to help, and from here the story of insulin started. Then insulin was purified and crystallized in 1926, and amino acid sequenced by the Sanger. And if you go into the modern genetics, there is a Sanger sequencing, you see. So Sanger sequencing is this insulin was purified and crystallized, and then amino acid sequence was done by the Sanger in 1960, and complete synthesis was in 1962 by the Hodgkin, and radioimmunocell insulin by Yellow in 1978. So look at this. Benting, McLeod, Best, Collins were awarded the Nobel Prize in 1923 for the use of insulin in the treatment of diabetes mellitus. So it's a teamwork. Benting, McLeod, chemist, pharmacist, and medicine surgeon, you see. But unfortunately, we are diverging, we are not converging. This is a dilemma of our country as well. So integration of different transdisciplinary integration is important for improvement. But what I want to give you message is that the story started from 1869 and it went on to 1978. It's more than 100 years. Development is तरह होती है. Next slide, please. Cells that secretes at the level of pancreas, there are B cells, alpha cells, and beta. B cells secretes insulin, that is, and insulin produces hypoglycemia. Glucagon is secreted by the alpha cells, and alpha cells secretes hyperglycemia. You see A cells, you see glucagon, and by B cells, that is related to beta cell, that's 75%. That's insulin and proinsulin secretion. There are delta cells that secrete others, hormones, and F cells are there. Next, please. This is the structure of insulin that I have taken from the internet. It's an image maybe copyright 21. So whoever that is, that's their copyright, it's not mine. So you see, insulin comes and attached with surface receptors, and then it is internalized, and once it is internalized, so it works. Yes, please. Mode of action of insulin. As I told you, insulin plus specific surface receptors. Then this complex is internalized by endocytic mechanisms. There is inhibition of cyclic AMP that stimulates phosphodiesterase. There is less glycogen in the ground. Consequently, glycogen synthetase is stimulated, and the utilization of glucose is increased. And if you recall your memory, in the previous lecture, we talked about that utilization of glucose is increased. Drugs that also increases the peripheral utilization of glucose, and that is backward as well, you see. So in certain cases, there is insulin-resistant diabetes mellitus. And once there is insulin-resistant diabetes mellitus, so metformin is a drug, biguanides, metformin, fenformin, that will increase the utilization of glucose. So in case of insulin-resistant diabetes mellitus, sometimes we give metformin, we give biguanides, so that to synergize the effects of insulin. So it is used in the management of hyperglycemia and diabetes mellitus. But this point is important. The down regulation of receptors in obesity and up regulation of receptors in diabetes. This is important. It's a technical point to remember. Down regulation means number of receptors decrease, and up regulation means that is increased as well. So this is important. That is why obesity is usually preceded. This is followed by diabetes mellitus as well. And WHO has declared obesity as disease of the millennium as well. So we have to focus on obesity. In the last video, we talked about that gluconides, you see, increases the peripheral utilization of glucose. So we said that hyperglycemia is a syndrome. So a person a patient being received by you with hyperglycemia is not necessarily that person is suffering from diabetes mellitus as well. Next, please. Next. These are the metabolic effects of insulin. So these membrane effects. Glucose transport is increased. The amino acid transport is increased. Fatty acid transport is increased, and the cellular uptake of potassium and magnesium is increased. One is the membrane effect, and the other is the intracellular effects inside the cells, intracellular. So, regarding intracellular effects, it increases the RNA and DNA synthesis. As I told that these surface receptors, insulin receptors, that comes and attach with the surface insulin receptor, then it is internalized through the endocytic mechanisms, and once it is internalized, so it produces these intracellular effects. These increase RNA and DNA synthesis, increase protein synthesis consequently, stimulation of glycogen synthesis, and stimulation of glycokinase, inhibition of glucose 6-phosphatase, increase lipogenesis, decrease lipolysis, increase cyclic AMP synthesis. Inhibition of cyclic AMP synthesis, and increase magnesium activated sodium potassium ATPase activity. Consequently, the glucose level fall, there is inhibition of lipolysis, muscle protein synthesis is facilitated. So those who are on insulin preparation, they gain weight as well. So weight gain will be an adverse effect of the insulin. But we just estimate from that, if the patient weight gain, you see, and on the second visit that comes, and his weight is increased, then that is an indication that the insulin has worked as well. You see? Next, please. These are insulin preparations. Fast-acting insulin preparation, intermediate-acting, and long-acting. Regarding fast-acting, you see, this is regular or crystalline insulin, and from INS or zinc suspension. Intermediate-acting mean isoprene insulin zinc suspension, globin zinc insulin preparation, and long-acting mean protamine zinc. You see, extended zinc insulin preparations. This time is important. Time of action and time of injection, that is important. You see, I have used this oblique symbol. And onset of action, that is also important. So fast acting, usually it acts after an hour. Once you inject that, once you get that administered, so after an hour that works, the fast acting. The intermediate acting works after 2 hours, you see. And there's another class that's zinc suspension, that is from 2 to 4 hours. Whereas long-acting insulin is working from 4 to 6 hours. This concept is important. These are important, especially once your patient is not managed with oral anti-diabetic drugs. So once your patient is not managed with oral anti-diabetic drugs, then we take the support of exogenous insulin. And once we are taking the support of exogenous insulin, so the time of onset of action is important of different insulin preparations, because this will determine your skills, clinical skills, how to what you can say regulate the blood glucose level. Then the time of action and injection, you see, so 5 to 7 hours, you see, this is, and before breakfast, this is fast acting or regular acting, and this is also before breakfast, and its time of action mean for how long it will work here. So from 12 to 16 hours, and from 18 to 24 hours, and 18 to 24 hours. This also is an intermediate acting. But this is interesting, you see, for protamine zinc and long acting, you see, that is 24 Selega, that is 36 hours. And one thing is important point to know, that long acting is you can take at the breakfast as well. But short acting or fast acting and intermediate acting, all these are taken before breakfast. So an assessment in MCQ may be said as that which type of insulin preparation are usually administered before breakfast. So the answer may be fast acting, intermediate acting, or the examiner may take an example from this, or this. But there may be another question like that regarding which particular insulin preparations are usually taken at the breakfast. Mean sath. So there may be different options, and one option may be like long acting, intermediate acting, and short acting. So this option is important, you see, because this is knowledge gained by others. How you are going to use this knowledge, this is important. Now, these are the time of hypoglycemic risk. For example, late morning, your patient got administered insulin, and a mishap or is a call that Mr. So-and-so or Mrs. So-and-so died. So you got administered insulin, but at the same time, you missed the meal. And once you miss the meal, so be ready for the hypoglycemic shock. You understand that? So this is important that once your patient has been administered insulin, so take care of her diet as well, because they are supposed to take meal, because meal is a source of energy, meal is a source of carbohydrate, and if it is not followed by, your regular habit and habitat, food related habit and habitat regular that you are going to take in your daily routine, and you miss the meal, so risk of hypoglycemia is increased. And once your patient are managed diabetics, your patient are managed, mean that your patient is controlled either with insulin or with oral anti-diabetic drugs or a combination of both of them. Then you should take care about your daily regular routine that you have adopted. But if you miss, and remember, you miss the meal, so the drug is blamed. So we should not blame the drug. We should blame the recipient and the person who is going to give instruction to the patient. So patient counseling is important as well, particularly once you are going to administer your patient insulin. So next please. Therapeutic uses, but I will carry you back to the next slide as well. I will carry you back. Yes, back please. And let me take the support of board as well, so you can arrange your